Good afternoon. Good afternoon.
Good afternoon.
There we go. Thank you all so much for coming. I am Malcolm Woodland. I'm the Executive Director of the Caucus on the Commission on the Social Status of Black Men and Boys. So happy to have you here for this really important discussion. Unfortunately, I have to start by bringing regrets. Congresswoman Wilson's flight was delayed. So unfortunately, she cannot be here to join us this afternoon, but she certainly wanted me to tell you all how happy she is to be a part of this discussion and to have sponsored this discussion. She and I have been working over the last several months on this discussion with our partners at NCQA, and also on a bill that we've been working on to address health disparities. So again, so excited to have this discussion. If I were Congresswoman Wilson, I know what she would say. She would say, call me Congresswoman Frederica Prevention Wilson, right? And if any of you all know the Congresswoman, you know that's what she would say. And usually when she's talking about prevention, she's talking about preventing black men and boys from falling into the school to prison pipeline. She's usually talking about preventing black men and boys from becoming involved with mass incarceration and being victims of mass incarceration. But today, we're still talking about prevention, but what we're talking about in this case is prevention of health disparities, prevention of diabetes, prevention of hypertension, prevention of all of these other hugely important things, prostate cancer, colorectal cancer, that are also preventable, gun violence, right? These are the types of things that are also, unfortunately, ending the lives of black men and boys far too early. And not only black men and boys, right? Everyone is impacted, or mostly everyone, is impacted by some kind of health disparity, right? So that's going to be our discussion today. I also know she wanted me to point out that, in part, we've talked about health disparities before. But what's going to be different about this discussion today is we're not only talking about health disparities, but we're engaging with the people on the ground who are doing something about it. And that's what we're excited about. I was talking to Dr. Buckley, and Dr. Buckley, our moderator from NCQA, he said, we have talked far too much about the problems of health disparity. We know so much about that. Today, we're going to talk a little bit about who's doing something about it and how we can do something about it. So very excited to have this discussion. And now I'd like to bring up our moderator, Dr. Buckley.
Good afternoon, everyone. How's everyone doing? Doing pretty good? So, as Malcolm mentioned, my name is Dr. Brian Buckley. I am the Director for Health Equity Initiatives for the National Committee for Quality Assurance, NCQA, where I lead our NCQA's enterprise-wide strategy around health equity and really how we embed it through all our offerings. A little bit about NCQA for the folks that are not familiar. NCQA is a nonpartisan, nonprofit organization with a vision to drive better healthcare, better choices, better health, improving the quality of healthcare and the lives of all Americans. This will be an informational briefing. I get the wonderful opportunity to be here with some amazing panelists. And participation from our panelists and NCQA staff does not represent endorsement or support for legislation or political action discussed or referenced during the event. But we're here to talk about how we actually make action happen, so I'm really excited about that. So I'm excited to moderate this panel and taking data really into action and how we advance and partner to advance whole person health. Before I go into our panel, I want to take the time to make some acknowledgments. One, I want to acknowledge and thank Chairwoman of the Caucus, Congresswoman Frederica Wilson. I know she could not be here, but Malcolm, I think you definitely embodied her words really well. And I know she really has been involved from day one in this process. I would also like to acknowledge Congressman Stephen Hertzford, which I believe is here. And if you want to make any remarks at all, let me know here. Yep, yeah.
Good afternoon, everyone. Thank you for joining. I am Congressman Stephen Hertzford from Nevada's 4th Congressional District and proud to serve as chair of the Congressional Black Caucus. The Congressional Black Caucus is pleased to partner with Representative Frederica Wilson as the founder and chair for the Commission on the Social Status of Black Men and Boys, and I'm proud to be a commissioner on this organization. But for the leadership, for today's convening, and the opportunity to really learn from data-driven policies and recommendations on how we can improve the health disparities facing Black men and boys. We understand within the CBC as policy makers that it's our responsibility to the communities that we serve to find solutions to long-standing disparities that negatively impact all of our communities. And we're intentional by focusing through disaggregated data on Black men and boys, we can improve their health outcomes, which really improve the health outcomes of the entire community. Today, we have to urgently address the health disparities facing the Black community, and particularly those that disproportionately impact Black men and boys, who too often face disparate health outcomes, and the truth be told, face disparate health access, which affects their health outcomes. Illnesses such as diabetes, prostate cancer, hypertension, and more target Black men and boys at a much higher rate. In their lifetime, 1 in 6 Black men will develop prostate cancer, compared to 1 in 8 men overall. As we are 1.7 times more likely to be diagnosed with cancer, we are also 2.1 times as likely to die from the illness. Around 40% of Black Americans are diagnosed with hypertension, which subsequently leads to a higher rate of strokes. On average, Black men are 70% more likely to die from strokes compared to white men. Rates of diabetes have increased 160% for Black males between 1980 and 2020. Gun violence remains the #1 killer of Black men between the ages of 15 and 44, which has been the case for nearly a half century. So yes, while we know the problem, we do have to center the reality that many of these issues are because of a system of racism and discrimination in this country that are embedded in our institutions, in our policy, and in the choices that have been made since the founding of our nation, sadly. But that doesn't mean we can't and shouldn't do something about it. As we can see and will hear from the panelists, the data and research are clear. We have to recognize that there is a health epidemic facing Black men and boys. And I'm, again, proud as chair of the Black Caucus that this year not only have we made protecting our democracy and the cornerstones of our democracy an important part of the work that we're doing, but we've also launched an agenda around Black economic prosperity and wealth. And I'm proud that 100% of the members of the CBC have co-sponsored this initiative to build a Black wealth agenda, because when you improve the economic conditions of Black people, you actually improve their health outcomes and you save Black lives. So I want the panelists and those of you who are part of this briefing to know that the Congressional Black Caucus is here as your partners in this work. This briefing and the work that the Commission is doing every day is important to advancing solutions for the people who need it the most. Again, I want to thank Malcolm, the commission, Dr. Bradley, and all of the panelists, and those of you who are in the healthcare field. I've been doing a lot of work with the medical school in my district, which was just opened recently. We are working on a new partnership between that medical school in Las Vegas and HBCU medical schools across the country to develop more partnerships and, again, access into the health field at every level, in every position. But we will hear from you in this briefing. We will work to take your innovative ideas and your policy recommendations to address health disparities in our communities for the commitment for improving the lives of all the constituents that we serve. We cannot continue to talk about these problems without addressing them. And you have the commitment of the Congressional Black Caucus that that's exactly what we will do. So thank you for allowing me this opportunity to come by and to kick us off. I know votes have been called, so I won't be able to stay, but we have our team members and staff who will hear the conversation, and we'll make sure to share it with Congresswoman Wilson and the rest of the commissioners. Thank you.
Thank you so much there, Congressman. And just want to make sure, are there any other congresspeople in the audience that would like to say a few words? Seeing none. I also want to acknowledge the amazing staff of all the congressional members. It has been definitely a labor of love of putting this all together. I just want to thank you for all the work that you've done in really helping put this event together. I also want to acknowledge our NCQA leadership and staff, specifically our founder and CEO, Peggy O'Kane, here in the audience. For 35 years, Peggy has led NCQA with the vision of improving healthcare and advancing health equity. Through her leadership, NCQA has become the nation's leading accreditor of health plans and a strong, unwavering voice for health equity. So thank you, Peggy. And then last, don't worry, that's the last acknowledgement. All of you for being here, and also for all those that will be listening online and or listening to this recording. Thank you for being engaged in this work. The fact you're all here means that this is important to you as well, and that just definitely warms my heart. So with that, I would like my panelists to come to the table here so I can do my awesome introduction of them. So the hardest part when you have to actually do moderation is like read people's bios. And I was like looking at their bios and I was like, man, like we gotta keep these short. If I read all of their bios, we would use up all the time. So I've done my best to try to summarize their bios as best as possible, but I just want to acknowledge that they are doing so much awesome work. I couldn't even fit into all 50 words here for each one. And definitely encourage you to engage in their scholarship and their work in their organizations. So the first person I would like to introduce to my right, and I'll go down, is Dr. Crystal Clark, Chief Medical Officer for Community Health Choices with UPMC Health Plan, headquartered in Pittsburgh, Pennsylvania. She's also Senior Advisor for the UPMC Center for Social Impact. Dr. Clark provides strategic, programmatic, and medical leadership for the UPMC Community Health Choices team dedicated to supporting improved independence in the community and overall health and wellness outcomes. Welcome, Dr. Clark.
Thank you.
Next, I have Matthew McCurdy, Executive Director and co-founder of Black Health, a nonprofit that develops public health innovations to overcome the barriers created by racism and improve health outcomes for Black people. He also serves as the Director of Programs of Health Design ED, the Acute Care Design Plus Innovation Center in the Department of Emergency Medicine at Emory University, where he leads the development and implementation of innovative solutions that improve patient outcomes. Welcome, Matthew. Next, we have Dr. Tali Tali Bang, Vice President of Health Equity at Hennepin Healthcare Systems in Minneapolis, Minnesota. There, she focuses on eliminating health disparities, improving diversity, equity, and inclusion overall. She serves as a thought leader and has created trainings and presentations to assist others to better understand the psychology behind oppression, organizational change, and culturally appropriate care. Welcome, Dr. Bang. Last but not least is Dr. Derek Griffith, founding co-director of the Racial Justice Institute, founder and director of the Center for Men's Health Equity, and professor of health management and policy and oncology, all of those things at Georgetown University. He also serves as the chair of the Global Action on Men's Health, a global men's health advocacy organization. His research has explored how notions of manhood, trustworthiness, intersectionality, and individual tailoring can be incorporated into community-based and policy strategies to promote health and well-being. Welcome, Dr. Griffith. So see, I did a good job of there, trying to abbreviate their bios there. So, but as you can see, we have quite an awesome panel with us here today. So we'll just get straight into it. The session's title is Healthcare in Action, and you've already heard from my previous speakers, we know about a lot of the data that is happening. And often when we talk about data, we're usually talking about the quantitative. But we also need to acknowledge that the qualitative data is also very important. And both are really important in addressing health disparities. So Dr. Griffith, given the fact you've spoken to this group here before and your role, can you set the stage for us and tell us a little bit about the state of health among Black men and boys in the US, in addition to what you're seeing as strategies to advance health equity?
Good afternoon.
If you could press it there.
Good afternoon.
Some mic check here real quick. There we go. There we go. They are all green.
There you go. Thank you. Good afternoon, all. It's a pleasure to be here with you. As far as setting the stage and the foundation, obviously we wouldn't be here if we didn't already know and acknowledge that Black men have particularly poor health and poor health profile. And when we think about that, we're thinking about big picture measures in addition to what Representative Hertzford already mentioned. Things like shorter life expectancy, higher rates of premature mortality or dying before the age of 60 or 70, and less likely to have insurance coverage and more likely to be uninsured. And so it's important to just recognize that we're going to also focus in our conversation about the role of health and healthcare in this particular conversation. We know that having access to healthcare is an important part of the things that people can do to improve their health and well-being, whether it's seeking out preventive care or whether it is receiving care once they're actually ill or in need. When we think about some of the things, again, pulling off of what Representative Hertzford said before, we know that stress, particularly from economic factors, are one of the leading causes, one of the main determinants of why men have poor health and well-being, and a lot of times men will prioritize their financial success or their jobs and so forth more than their health and well-being. And so part of the ways that we have to think about this connection between economic factors, stress, and depression, and poor health is recognizing that those are major determinants of those issues. I also just want to acknowledge, I was talking about some of the work on uninsurance, access to care, and so forth. And so Dr. Inya, who's in the back, did his dissertation on that work, so we can ask him in the reception about all that good stuff. But the last big thing I just wanted to say is, you know, this pattern is not new. We tend to talk about these issues as though they came up, you know, in the last several years and so forth. For at least 120 years, Black men have had a shorter life expectancy than other groups of men and women. And so we have to think about, when we talk about solutions and strategies and doing things, we have to think about it in that larger context. This is something that spans space and time, and we have to think about and recognize there's a larger picture that we have to consider.
Thank you for that, Dr. Griffith. And as we now switch, and really you did a good job in setting the stage, I want to turn to you, Matthew, because your organization is really in the action of focusing on how we actually address these systemic barriers impacting the health of Black communities. Can you share how your organization does this work and how you all partner with healthcare organizations?
Yeah, absolutely. Well, that was louder than I thought. So at Black Health, we're a nonprofit based in Atlanta, really focused on the impact of racism on health outcomes for Black people. And it's important that we say racism and not race. You know, often there's a lot of blaming around the stats that Dr. Griffith just named, right? So we talk about dying sooner, we talk about getting ill or getting sicker more frequently. And we point to racism as a structure that then limits the opportunities and access to health for our communities, and not race as an individual attribute that then leads someone to be unhealthy. And so the way that we're really thinking about enabling community and community health is the resources exist, right? And we really see ourselves as bridge builders, right? And so I want to look at communities and say, hey, you all want to be healthy, right? And that's a myth that we're also overcoming, that Black communities don't want to be healthy, don't want access to health resources. And then we connect them to health systems, to social service providers, and also just like community well-being activities. And so our work is really focused on, one, how can we educate current providers, current healthcare workforce on the impact of racism on health outcomes, and then secondly, and more importantly, I think, how do we then equip them to do something about it? And so the way that we work with health systems, again, is really as bridge builders. We'll dive a little bit more in some of our specific work, but what I really want to create at Black Health is a funnel, right? How can I go in communities and say, hey, this health plan, this hospital system, this network really wants to connect with you all. We know that there are trust issues because of some of the things that we've talked about, we'll talk about, right? Because of some of the stigmas around health. And then we want to bring that bridge towards those health systems. And so we're really working to elevate the importance of health in our community, but also realize that there has to be an extension in the hand that comes from health plans and health services to our community.
Thank you for that, Matthew. And I love that you talked about the idea of trust. And I think actually WMC actually came up with a new resource around trustworthiness and how we actually think about that. So as you mentioned, there are a lot of solutions out there. So now I'm going to turn it to my healthcare organizations here. So Dr. Vang and Dr. Clark, your organizations partner with community organizations to address the needs of members really in this holistic way. Can you talk about your journey in getting there and how your organization has shifted its focus to an equity lens? So I'll have Dr. Vang go first.
Thank you, yes. I live in Minneapolis, Minnesota, and I also work at a level 1 trauma center, a safety net hospital located downtown Minneapolis. So shortly after Mr. George Floyd was murdered, our hospital system and the county commissioners declared racism as a public health crisis. And so the safety net hospital system that I work in, we mobilized and we took action. We created our first ever health equity department. And the first people who worked in the department, we were just the 6 of us that worked in that department. And we really made it a point to prioritize health equity, specifically anti-racism, into the very fabric of the work that we do because of the patient population that we serve. It was not an easy thing to do, as you might imagine. Throughout the history of healthcare, resources have always been limited. People are always fighting for resources. And to prioritize health equity at a time where it was the height of COVID and the civil unrest, it was difficult to convince leadership across the institution. What worked for us was our board of directors was supportive. Their values were in line with ours. Our CEO was supportive, and our first Chief Health Equity Officer, Dr. Neka Cedarstrom, really paved the way for us. And so what we were able to do was align health equity to quality and safety issues. In healthcare, quality and safety is everything. And it hasn't been seen that way when you think about racism and the ways in which it impacts the health outcomes of people of color. And so we've aligned that, and then we've also committed to training all 7,000 employees through a full year program on anti-racism, really health equity and how racism contributes to health disparities. These things have all kind of come together for us to really be able to amplify the work that we do. So we were a team of 6, now we are a team of 160 people in the health equity department.
Thank you, Dr. May. Dr. Clark.
Thank you. So I'm a chief medical officer of one of the lines of business for UPMC Health Plan. We're headquartered in Pittsburgh. We have about 4.5 million members. We're the second largest provider-led health plan in the nation, and we have about 6,000 employees. And we had committed to diversity and inclusion for quite some time, for over a decade. We actually have a diversity and inclusion subcommittee of the board of directors of the health plan, and our CEO presents to that subcommittee every time we meet. So we were already invested in diversity and inclusion, but similar to my colleague, the murder of George Floyd made everybody look at what we were doing more critically. And we decided that there must be something more we could do. And we could take a position of truly being an organization that was against racism. So not just trying to eliminate disparities, but putting a flag in the ground that, racism is not something we tolerate, it's a public health emergency, and there must be more that we can do. When we looked at the services and the care that we provide, and we looked at the literature, and we had this component of real moments with the murder of George Floyd, we realized that only about 20% of a person's overall health and wellness comes from the medical care that they receive. Only 20% of your overall health and wellness outcomes. The other 80% is driven by your physical environment, your health behaviors, your social factors like your education and employment and income and your community safety. And you all probably know that statistic, it's in the literature. But sometimes you forget because you get so focused on, fantastic care, that's your commitment, and you don't stop and realize it's important, but if you don't address the other 80%, we're missing a real huge opportunity. So UPMC said we're committed to delivering excellent health care, but we also remain committed to investing and partnering with others to make a strong impact on these social determinants. Because if we do, that means we're giving our members their opportunity to attain their full health potential. And that's the definition of equity. So we made this commitment, and that manifested in the development of a Center for Social Impact. It's a program within UPMC, or an entity within UPMC, that coordinates and evaluates and expands programming and innovations that addresses social needs. And just a couple of brief examples of the center's work. We partnered with an organization called Benefits Data Trust, which is a nonprofit that essentially helps people access all services and benefits that they're entitled to based on their social circumstances. And we were able to get 1,342 people on SNAP and 181 people low-income home energy assistance program enrollments. That was just in 1 year. We also collaborated with some of our county administrators around emergency rental assistance, and we were able to help with the distribution of over $16 million into the hands of some of our members facing eviction. Because one of the best ways to prevent homelessness is to prevent eviction. And then the last example I would use is our community partners community partnership with an organization called Footbridge for Families. And this is another organization that collects donations and is able to give families short-term monies up to about $2,500, excuse me, when they're facing a crisis. So sometimes it's just a small amount of money that can keep you from eviction or keep you from some other situation. And with those, with that partnership, we were able to give out about $58,000 in 1 year. So these are examples of, as a health plan, paying attention to the population, but also knowing we have to step out of the traditional role of payer and partner with our other communities and social agencies, because we have to deal with the other 80% that's driving the overall health and wellness of our members.
Thank you for that. And there's 3 things I kind of heard as themes there too, just to reiterate those points. One, partnerships are important. And I think you both really spoke about partnerships, but also something that I think that Dr. Bang has said too, and something that we say often at NCQA, there can be no quality without equity. And so I think for both of you, your organizations, you both have talked about, this has been a journey we've been on for a while, and I always want to remind our audience about crossing the quality chasm, which talked about the domains of what high-quality healthcare actually is. And equity has always been, and this was back in 2003, and so, you know, for a lot of the organizations here, you're not just new to, but true to this, and been really going in this direction for quite some time. So getting a little bit more specific, Matthew, I'm going to turn to you, because as it was mentioned in the opening remarks, there are many different things that are affecting Black men. And I think specifically about colorectal cancer and some of the work that we're even doing around promoting race ethnicity stratification, and one of our measures is on colorectal cancer. And so I know your organization has done some work around colorectal cancer screening. Can you tell us more about the findings and strategies that might help others?
Yeah, I think, what we know about colorectal cancer is that our communities are definitely experiencing higher rates of colorectal cancer. We're getting diagnosed at later stage, right, so more difficult to treat. And then we're also seeing higher incidence among younger populations. So our work, and I think 3 values that we really learn from our work is 1, right, we have to work across the ecological model, right? So we have to think both about individual knowledge, skills, behavior. So we want to educate people on the importance of screening, when they should get screened. But we can't stop there, right? So we also want to then move up towards access, right? So thinking about how we actually change the system to improve access for screening modalities and treatment. And so the work that we've done in Georgia, but across the country, is really to lead at home and community-based screening, right? So we'll show up at your barbershop, we'll show up at your cookout, your health fair, your church. We will provide a screening modality that can either be done at your house, mailed to you, or you can, take it yourself and then go see your provider. But really trying to bridge that chasm of the access. We know that often our communities are in proximity to health systems, don't have a health center in walking distance or by public transportation. And so we equipped, I'd say, close to 20 other nonprofits throughout the country and enabled them to replicate our program and their nonprofit as well in their local markets. But we know that we also can't stop at screening, right? So once someone is diagnosed, we have to provide pathways into care, right? So, one, again, just to reiterate, across the ecological model, we want to think about knowledge, skills, behavior, but also access. We want to meet people where they are, so we want to be community-oriented. And 3, we want to think about care across the care continuum, from prevention to treatment, right? So not only did we provide a screening modality, we also thought, hey, we need to provide people opportunity to get a colonoscopy, to get access to care. And so we've partnered with health systems and recommend, when we implement our model in other places, that our nonprofit partners partner with health systems to create, again, that bridge, to create that funnel, so that once people are diagnosed, that they are able to get in care. We've also set aside close to $450,000 over the last 3 years to pay for colonoscopies for people and to help support care, right? So providing funding and also a tool to then support people's access to health promoting resources. And so I really, what we've learned from this model, again, just to reiterate, is that people want these services, right? We're not seeing low screening incidents because Black men, Black women don't want to be screened. What we're seeing is there's an access issue. There's an education gap sometimes, and they don't know that they should be getting screened at 45. And even younger if you have a family history of colorectal cancer screening. I'm gonna say that again. Younger than 45 if you have a family history of colorectal cancer screening. So the work has really been around, again, enabling people to get those resources and then providing opportunities and pathways that fit the everyday life of our community to then get the care that they need.
Thank you for that. And I think the one thing I really want to stress is meet people where they're at, like Public Health 101 right there. And I've even benefited from being in the barber chair and hearing my barber trying to explain to me about screenings. I was like, oh man, something's changed here. So as we talk about, and we're gonna, as we talk about, you know, just aspects of data, I want to kind of go back again too, because I think there's something important. As we talk about data, we usually talk about data in these one dimensions oftentimes. So Dr. Griffith, and especially now that OMB released its new race, ethnicity, and expanded the categories, in addition to information that we know about demographics and location, when we talk about health equity, often we don't talk about disparity. We often, as I said, talk about it in one dimension. Can you share the importance of looking at things in compounding disparities and the impact that can have on Black men and boys?
No, thank you for the question. So just by way of context, the Office of Management Budget just released new guidelines about how they want to help people to categorize race and ethnicity. And typically, historically, it was two separate questions. There was a question about race, and then separately there was a question about ethnicity. They did a lot of work to basically figure out that that wasn't the way that people made sense of it. And when they asked the questions, they were not getting the answers that were aligned with what we were trying to capture. So what they did is collapse race and ethnicity into one category, and so now there's 7 categories, including Hispanic as a category that is in line with looking at race, another category, in other groups, and then also broke out Middle Eastern, North African as a separate group. So essentially what they did was disaggregated the white category into those 3 groups, and then added that to American Indian, Alaska Native, Asian, Black and African American, and Native Hawaiian or Pacific Islander. That's just context. All of those issues are important. Race, ethnicity is really important, but it also often masks the issues that we see by gender. And when we talk about gender, usually in policy, gender tends to be synonymous with women and girls and doesn't tend to actually give us better insight to men and boys. And what that has led to is that men and boys are often falling behind when you compare them to their female counterparts within a particular racial and ethnic group. And that's what we tend to be missing when we're looking at these issues. We've seen over, again, this 120 plus year period, the gap, particularly between Black men and Black women, has actually grown quite significantly, almost 8 times in terms of life expectancy, in terms of, let me say it differently. In 1900, the gap between Black men and Black women was about a year. In 2021, it was 8.1 years. So it has grown quite significantly over that time, while the racial gap between Black men and Black women is actually, between Black men and white men is actually closed quite significantly to about 1.5 to 2 years. So the question is, how do we make sense of this? Why is it that our technology and all the other advances have actually not equally benefited these groups? And when we tend to think about equity, we don't tend to think about it or talk about it in relation to both gender and race and ethnicity. We tend to only look at one factor at a time and don't intersect those two in ways that give us insight into these issues. So just another concrete example with the issues around colorectal cancer, we know that Black men have a higher rate of dying from colorectal cancer and pretty much every other cancer that is sort of a leading cause of death, but we don't tend to actually capture that or tend to focus on those issues, which is why we're missing them. And so it is important to, while it is progress that we've disaggregated these groups, they actually had just one other quick thing. It's interesting to read the Federal Register and their sort of discussion. They had a big discussion and process for looking at should they disaggregate the Black or African American group. And there was some discussion and interest in seeing, do we need to separate descendants of slaves in the U.S., paraphrasing, from those who are immigrants and so forth, or descendants of more recent immigrants, let me just call it that. And they decided not to for a lot of other political reasons, but they did know that that was something that we need to begin to look at going forward, and one of the next steps is going to be looking at how do we think about that. I mention that to say that a lot of the issues that we know that are true of other groups, Asian Americans, Hispanic, Latino populations, and so forth, in terms of immigrant populations doing better, we also see in Black communities, we just don't tend to document it. And we have very different health patterns when you actually start to disaggregate Black people by, country of origin, by other factors and so forth, but we don't tend to have that information. So there are different ways that we need to really start to break these things down to be able to see the kinds of things that we're talking about. Last quick thing is equity. I would call, the best way to think about equity for me has always been as an evaluation term. And you really have to, and the reason that we're having this conversation about data and why data are so important is you can't actually document that you're getting closer to equity. Data is basically essential for all of this. If you don't have the data, you don't know if you're making progress, you don't know if you're getting worse, if you're getting better. It's all about data and how you organize it, present it. And so these choices that we're making about what do you stratify, and do you basically just separately present race and ethnicity separate from gender? Do you bring those together and be able to look at some of these subgroups? Do you look at subgroups of the Black population? Those are all decisions that we have to make, and each organization, institution has to make, and that will help us to guide in what we can see and what we can't as it relates to health equity.
Thank you, Dr. Griffith. And I think you mentioned so many important points, both in that macro. I'm going to actually turn it to my clinicians, Dr. Clark and Dr. Thang. You're both clinicians, and you get to see this on the front line. And so, kind of given everything that Dr. Griffith has talked about, and specifically kind of in the spirit of thinking about cancer and other chronic diseases that affect Black men and their families, can you allude to any things that you're seeing on the front line? And so I'll start with you, Dr. Clark.
Sure, Sue. Yeah, so, one of the things, and you heard the Congressman talk about the difference in statistics, and some of my colleagues as well. Just as a general rule, Black Americans have a higher mortality rate of any racial or ethnic group in all cancers, pretty much combined. And the life expectancy is shorter. So, I'm not trying to be simplify something so horrific, but that's really what it boils down to. The challenge, particularly for Black men, and as a health plan, we look at populations and subpopulations, is that we have, of course, we have Black women who access healthcare services and are covered by insurance. But there's a huge swath of individuals who use healthcare services intermittently or the emergency room. And so we don't have an opportunity to really build a relationship and help them understand how to invest in the time that it takes to get on a trajectory of ideal health. And that's not really just a personal decision on personal behaviors. There's a lot of challenges as a Black man to enter the healthcare system, to deal with the things that are being asked of you. And also, we tend to focus on problems that patients have, and I call it blaming the victim. If a person comes in and they haven't had their colonoscopy and they still smoke, and yes, those are personal decisions at one level, but at the same time, if menthol cigarettes were disproportionately marketed to your community, and that's what you grew up on and heard people talking about, was it really a completely personal decision? Or were you influenced to do this from external drivers? When you talk about colonoscopy, if it takes 6 months to get an appointment, it took me 6 months to get my own. It takes 6 months to get an appointment. And you're in a situation where things change in your circumstance from month to month. is it really your fault that you're behind on your colonoscopy screening? So I think one of the things we really have to do is not just meet Black men where they are, but also make them understand that a lot of what they're facing are challenges that are not of their own making, and that we're here to help support and jump over some of those barriers as we can. And as you heard my colleague talk about some of the things that they're doing in their communities, we're partnering with an organization in Philadelphia, a Black Men's Health Organization, that does a massive screening every June. It's supported by Congressman Sharice Street, and the community has started to actually accept and look forward to. This is a place where Black men can talk about their health status honestly. They're not going to be judged, and there are also resources there to connect them to wherever they are, whatever access they have or don't have. And I think that is the way we're going to make a big difference in the folks that we just can't connect to because they don't necessarily come in the traditional door of healthcare.
And then you, Dr. Bank.
Yeah, I'd like to address the question from a psychological perspective. Couple of things, epigenetics and then chronic stress. Advances in science and technology have showed us that our genes, the ways in which our genes are expressed, can actually change or be impacted, I should say, because of our environment. So the study of epigenetics is the study of how our environment and our behaviors impact that gene expression. This is important because people who have encountered significant traumas, for example, can have their gene expression impacted. And this means that they can actually pass this on to their offsprings, and then it can be carried forward. There's been studies that have been done on communities with significant historical trauma and have found that 3 generations later, their children are more prone to higher levels of anxiety or depression. So these things, these societal factors impact us at a very, very deep level. Now, chronic stress is also something that our sciences have been able to share with us, that there's a direct correlation between how stressed we are, how chronically stressed we are, and how many health issues we have. So for example, studies on immigrants and refugee populations, studies on people of color have shown that they have higher rates of type 2 diabetes, hypertension, inflammation, gastrointestinal issues. It's not a surprise, because when your body is in a constant state of fight, flight, or freeze, you're always ready to protect yourself. And our bodies break down after a while. We're not meant to be in that constant state of stress. Now, Black men and boys are often perceived as threats in this country. They have to navigate new situations in ways where they have to be aware of whether they are safe or not. And this constant checking of, can I be who I am right now, or do I need to quiet myself down and seem less aggressive? That's a constant chronic state of stress, fear, and hypervigilance that puts their bodies always on and ready for that fight, flight, or freeze response. So because of that, and knowing what our science is showing us, we know that it's not victim blaming, we know that it's not just access, and I will even say it's more than social determinants of health. It is in the very fabric of our society. It is racism embedded in every system that we really need to be tackling when we're talking about health equity here. Thank you.
Thank you. And one thing that I think for the audience and those listening is one of the words that I really dislike a lot in healthcare is compliant. You know, this idea, Dr. Griffith knows my thoughts on this quite a lot, where we talk about, oh, that person didn't win. Now, often when I am hearing folks talk, they're like, well, they made that choice, but we're not also thinking about that built environment. And that trauma, historical genetic trauma, that also impacts decision-making on how they actually live. So thank you both for really alluding to those psychosocial aspects that are very important. And I want to turn to you, Dr. Griffith. Are you seeing also, they talked about the front line. What are you seeing at the national level related to this?
So let me just work backwards actually from something Dr. Bang was saying. When you think about chronic stress, one of the links that, I don't know why I feel like I'm Dr. Inya's agent today, but we worked together on a paper that was explaining why black men in particular had higher rates of COVID and mortality from COVID during the first period. And what we found is, and the question was, what was the link between COVID and COVID mortality and the pre-existing conditions? And the answer was stress. And it was basically having to name anti-black gender racism and understand the unique ways that it affected black men that helped to explain why black men had such a high rate of premature mortality during the COVID period and from COVID. And that, you know, black men already had the shorter life expectancy, and that actually was exacerbated and was made worse during that period. So I think it is just recognizing those kinds of issues. Unfortunately for black men, the other interesting thing, and building off of Dr. Bain's comments, there's a book called No More Invisible Men that Dr. Adia Wingfield wrote some years ago that was looking at the experiences and the more psychosocial qualitative experiences of black men who were in corporate America in high-income jobs and so forth, and they were doing exactly what she was describing. They had a higher rate of having to manage, control just how they responded to things, their voice inflections, how loud they spoke, how physically, how close they got to people, just all these different things that, that hyper attention to how you're responding to things naturally and whether or not you are, have the right to actually have a legitimate, honest response to things, wears and tears on your body because you're having to put energy into modulating yourself, regardless of whether or not you actually have a reason to be angry, upset, indignant about whatever it was that you've experienced. And because it doesn't matter the accuracy of that, and it doesn't matter whether or not you were right, the fact that you're going to put your life in jeopardy because you respond appropriately to something is part of what black men are dealing with that makes it unique.
And that is so important as we're kind of just thinking about this conversation. And once again, I want to remind, we're thinking also about that action. And so Matthew, I'm going to turn to you because you heard a lot from your fellow colleagues about the aspect of victim blaming and shifting this historical trauma, and what we're also seeing at the national level. Are there opportunities that you see that healthcare and other organizations can take to advancing health and wellness for individuals and communities, but more specifically for black men and boys?
Yeah, y'all see me up here taking notes. I'm just learning so much at this moment. Before I answer that question, I do want to touch on something that Dr. Clark mentioned, and I think Dr. Van also touched on as well, but also just really bringing it home and thinking about on the ground. That sort of shame around health that black men experience, and being honest about our vulnerabilities, and I think directly tied to the stereotypes built out of racism around being tough, being strong, having to not admit your weaknesses. My father was recently diagnosed with prostate cancer. Just completed treatment, he's going to be fine, he's going to be great. But he started to have conversations with his friends about his diagnosis. And sure enough, his homeboys are like, yeah, I had prostate cancer like 3 years ago. Yeah, I'm experiencing this now. Had never talked about it. These are his best friends, right? Had never mentioned it, had never expressed it. And I think it's a lot to do with what we're talking about, how that structural racism shapes your experience, shapes how you think about your health and your well-being, and then leads you to not communicate, to not even get screened oftentimes. And then I think driving back to your question, what we're seeing on the ground, I really enjoy innovative health partnerships, right? Thinking about how organizations from seemingly disparate areas, communities, come together to drive towards a health outcome. Black Health right now, we're partnered with Planet Fitness, with Advil, with Cottonelle, these large corporations who are seeing that they need to be invested in populations because healthier people buy things. But ultimately, when I can take For example, our colorectal cancer screening program, and I can take an organization like Cottonelle to see how their investment in helping Black communities will allow us to live longer lives, to be healthier. I can bring in a health system, right? So we're partnered with several health systems in Georgia, health systems across the country, and then also bring in community-based organizations, right? So organizations that normally would not work together, we're building bridges to build comprehensive programs that allow people to reach our health equity goals. And I get to sit on the other side of this in my job at Emory as well and think through how we can leverage the resources that we have, the expertise that we have, to then enable communities, again, to take a hold of their own health and their own well-being. And so we're actively seeking partners on the ground, folks who have access to community voices, access to community information, can mobilize people. And we're asking, how can we support you? How can we enable you to move your mission forward? How can we use our expertise and resources to supplement the things and the gaps that you may not have? And so I'm really excited about thinking more about how we bring additional players into this space. How can we bring organizations that we don't typically think about as health organizations and imprint the mission of health equity, and equity, as Dr. Griffith said, as an evaluation, like equity as an outcome, and not really thinking about equity as just a thing that we're doing. And so it's been really encouraging to see how we can bring new partners and different partners to this work.
Yeah, I love the aspect of private-public partnerships. And really, health equity, which those that have heard me talk, is definitely a team sport. And it's more so, how are we building a really nice, broad team? People that, and often when I even say about public health, everyone's in public health, they just don't know it yet. And so how are we really engaging people in this work and seeing what their contribution is to improving health and wellness in their given areas? So Dr. Clark, I'm gonna pick on you a little bit here. You all had a 5-star health plan star rating in 2023 for your Medicare Advantage work. And for those that are not familiar, 5-star rating is the highest score a health plan can receive. These ratings are designed to help patients understand and compare the performance and difference between health plans based on various quality metrics and outcomes, and improving health care quality through transparency and accountability. So if you aren't familiar, these are things that you can go look online and see about it. So we know more Black Americans are enrolling in these plans now. How are data and an equity lens help you work moving forward and striving for those high ratings?
So Medicare Advantage has really taken off. It's more than half of the eligible population that qualifies for Medicare has opted to go to Medicare Advantage, and there's some statistics that suggest it will be 60% of the population, the Medicare population, have opted to go into Medicare Advantage by the end of this decade. And as you said earlier, people of color seem to pick Medicare Advantage more often. And one of the things that we talk about is that it makes sense in a way, because Medicare Advantage pays for the things that traditional Medicare pays for, but it also covers other things, vision, dental, sometimes gym memberships. It depends on which plan you enroll in. And there's also a maximum out-of-pocket expense that you will have as a member, and that's disclosed to you right up front. So for people who are trying to make sure that they can manage their expenses but take care of their health, it seems like a very smart thing to do. The other thing is that for plans that have 5-star, those individuals, because of that designation, tend to have a very good experience as far as services, prevention services, and satisfaction, and those types of things. But there's some data that has come out from Kaiser Family Foundation, and they're a fantastic organization. They do a lot of great research in my mind, and really help us discuss some of these tough issues in detail. That there's concerns that maybe the quality of the experience for certain subpopulations, people of color in particular, may be obscured by the majority population in a Medicare Advantage plan. So even if you have a 5-star, there might be subpopulations within there that are not getting the ultimate experience that you want them to have. So right now, we don't want to rest on our laurels as a 5-star plan. One of the approaches we're using right now is our benefit design to drive equity. So essentially, Medicare allowed health plans to do something, participate in an initiative called the Value-Based Insurance Design Model, or VBID. And it basically gave you some leeway to use Medicare benefits to support people in things that could support them socially or help pay co-pays or whatever the case may be. And UPMC Health Plan was one of the health plans that actually joined the initial rollout of the model and helped test it. So what we do is we do health risk assessments and we understand what the challenges people are facing and social determinants of health is screened during that assessment. And we can offer benefits like $400 a quarter that people can spend on healthy food or pest control or household supplies or pet care supplies. We can give $100 a quarter for utilities. We provide social transportation to places like fitness centers, grocery stores, places of worship, salons. We can do in-home safety assessments. So those are some examples of benefits that we can give because we've been a part of this innovative model to meet our members where they are based on challenges that they share during these assessments. But we also know that we need to really drill down further and understand what is happening within subpopulations. And Dr. Griffith said it so well, there's so many things that can be obscured if you don't slice the data in a way intentionally and look for things, because many times things are hidden. So, you know, we are pretty poised. CMS is rolling out some new things you've probably heard about. The reward that's going to come from the Health Equity Index that's going to launch in 2027 around the star rating. So you will actually be able to get a reward if you're able to change your performance measures in areas where disparities exist. There's going to be a health equity management for utilization practice where we're actually going to be able to look at our utilization review, things that are approved or denied, and make sure there's no disparities that fall along racial, ethnic, and thanks to Dr. Griffiths nudging me, gender lines. And then there's also the physician payment rule of advancing health equity. So there's going to be ways for providers who provide training to help caregivers take care of people with certain diseases and new coding and payments for facilitating access to community-based social services. So what I'm saying is we've done it kind of at an individual level by assessing people's needs, and I think that's a great thing. But we also now know by reviewing the literature and hearing from exceptional subject matter experts like my panel that you have to dig down into the data just to make sure, you know, that everything you think is going well is going like it's going.
Thank you for that. And speaking of digging into the data, we know data stratification is a guiding work in providing new insights. And so, Dr. Vang, maybe even pulling back from the OMB conversation as well, what are you seeing also on the ground from the healthcare delivery space as well with that disaggregation of data?
Yeah, we strongly believe in disaggregating our data as far as down as we can. It tells us such important information. You know, it's not enough to disaggregate by race, but as mentioned earlier, even looking at specific ethnicities, looking at some of those factors, gender factors as well. You know, in Minnesota, we have a large population of Somali refugees or recent immigrants, and some research that has been coming on has been showing that when you compare the health outcomes and health disparities for the Somali population compared to the Black African American populations, there's differences that exist there. We don't know why yet in terms of, you know, what's driving some of those differences, But we miss those differences if we just group it all into one and then have one intervention that's supposed to work for everybody. And so we want to make sure that we're just aggregating this information, because if you don't have the correct diagnosis, you're not going to have the right intervention or treatment. And so I think about our health equity interventions, we're going to be missing the mark each time if we actually don't know what it is that we're trying to address. So from that perspective, that is something that we're doing. You know, our data is not the best data. You know, we use the EPIC system, and there's it's not the best categorization. So we are launching this whole initiative to reclassify our demographic information, kind of like what you were sharing, Dr. Griffith. And so that's something that we're going to be starting out with. But then we're also taking our health equity work from that data-driven perspective in terms of, let's take a look at which groups are experiencing the worst disparities in these different areas, whether it's outpatient, ambulatory, or inpatient, or certain screenings, certain chronic diseases, and let's really target those populations first and foremost, and then move forward. So it's not a, everybody at the same time kind of solution, but really that's the heart of equity, is who's suffering the most, who's the most disenfranchised, and then let's pour our resources into those communities first and foremost.
Thank you, Ben. As we start to get into Q&A, so start thinking about your Q&A, I just want to say a quick story just to really wrap this all up. So start thinking about your Q&A, and we'll have folks come to the mic. And really the impact that this work actually has on future generations. I was telling this at our Health Equity Forum the other day, and I had my firstborn child last year, and so I started really thinking about this idea of future people and really the impacts that we have today in really dictating their health. And I was thinking actually about my grandfather, which is my son's great-grandfather. Back in the 90s, he got diagnosed with prostate cancer, and he had a doctor that looked at that data. Before we were talking about data disparities, and knew that there was a disproportionate impact on people that looked like him, and took the time to work with him and get him the treatment so he's all right. My grandfather is one out of several other brothers, 18 children. Yeah, Pop was a Rolling Stone right there. And he had 10 brothers. And out of his 10 brothers, he's the only one that survived, because he took the time to get checked and had a doctor that saw him. And just to think about that one choice, how that one choice had him have the opportunity to see his great-grandson, to see me graduate with my doctor from Harvard, to see all these amazing things, 30 extra years. That's what we're talking about when we're talking about data. We're not just talking about these little dots, but really people's life and the ripple effects that can have on communities, and that wisdom that can be shared within communities. So I just want to thank our panelists again. A round of applause for them and for sharing all of their wisdom. So with that, what questions do people have? You could put your hand up and go to the mic back there. We will take a couple of questions. I see some people giving up.
Check. There we go. Sorry. I actually do have a question. Obviously, the care is paramount, and I really like how everyone was talking about the proper way to care and disaggregate data and focus on health disparities. Is there a business case for this, right? For Dr. Clark, for Dr. Bain, and as I think about fellow staffers who work with me and the pitch that they're going to have to make to their bosses, I wonder what kind of how do hospitals, how do providers continue to see profits, right, when you're expending this kind of resources on social determinants, things that people don't consider kind of hard medicine. So I wonder, I'm sure there is a business case for it, and I just wanted to hear you all talk about that a little bit as well.
I'm going to give you two answers. I'm going to give you you the answer from a health plan perspective, and then I'm gonna give you my personal answer. Health plan perspective. There's absolutely a business case. I mean, there's evidence out there, and don't quote me on this, the number, because I'm blanking on the source, but I believe it's about 1.7 billion a year that's attributed to excess healthcare costs because of disparities. So that money could be recouped if we didn't intervene so much later, or we're doing crisis care, ICU time, and we still may even lose the person. So there's absolutely a business case for helping everyone achieve their best level of health and wellness. You know, wellness is your ability to make conscious decisions about your health. Now, on a personal level, I struggle with the question of a business case for equity. I don't understand why we have to make a business case for fairness. Equity is fairness, that's what it is. And so, I'm speaking personally now, not for UPMC. So I struggle a little bit with that, and I say that with all due respect to everyone in this room. I understand the real world is we have to make a business case. But on a personal level, I struggle with that. You know, being unfair, especially in a country with so many resources, is really challenging for me. The one thing I say that we try and do, and now I'm speaking for the health plan again, is we try to engage the person on the street, our members, our community, in the dialogue around fairness. And we try and use language that is not, I mean, we're having this wonderful conversation about disparities and health equity indexes. Most people on the street don't know what those terms mean. We need to use those terms to talk to one another and make great progress this panel has described. But we also need to have the conversation with the individual, and they can get around the notion of fairness. That resonates. And so I think we need to spend a lot more time engaging the community in this discussion around fairness and equity.
I would agree. There is definitely a business case for this from a healthcare perspective. Currently, our emergency rooms are completely filled, packed. It's really, really hard to move people through the emergency rooms. Some hospital systems are seeing people in hallways because there's just no space. The throughput, meaning you go into the ED and then you get admitted into the hospital, oftentimes that's being delayed. There's a lot of issues right now in terms of the healthcare system that we are facing, and it's because people are sicker, right? We have a lot of people who are just sicker, and I don't mean even just physically, but a lot of mental health needs as well. And so if we are focusing on the preventative measures, there's going to be a definite business case. Now, since we're being honest, Dr. Clark, I'm being honest too. The other side to that is there are also services that bring in more money. Surgeries, right? Treating cancer brings in more money. Though that is also another reality that is true. So something that health systems need to get better at is really valuing delayed gratification as opposed to instant gratification. So knowing that the return on investment is coming may not be as evident right now. We do need to invest in these things, in these initiatives, before we see the payout. It may not be immediate, but it'll be there for sure.
I just want to add a epidemiology perspective, data-driven perspective to this case. David Satcher almost 20 years ago wrote a paper that was describing why there was a gap between black and white populations between 1960 and 2000. And what he found was that what was driving that were rates of infant mortality and the rate of mortality for 45 to 64-year-old black men. So if you need a case, a data-driven case for why we need to disaggregate this, it's because we do have a lot of interest in racial and ethnic disparities, but we don't pay attention to the fact that in most cases, men are actually faring worse than women within each racial group. And unless you're actually going to deal with that gender difference and deal with those gender patterns, you're not going to close those racial gaps that we actually care about.
Looks like we have one more question.
Good afternoon, everyone. Great panel discussion. Thank you folks very much for the insight you shared. My question is, when we look at communities of color, certain are pre-exposed to detrimental environments such as food deserts, poor air quality, and lack of access to upward mobility. How much do these factors play a role in developing chronic conditions in Black men and boys, and how do we capture the data from these marginalized communities? No pressure.
Who wants to take that?
And, from a public health perspective, that's everything, right? Our built environment, our communities, as Dr. Clark said, comprise of 80% of what's going to make us well, what's going to make us healthy. How we capture that data, I think, as Dr. Buckley started, is really just going and talking to people. I think we tend to overvalue quantitative data versus qualitative data, but I think if you go and talk to communities, they can articulate how having to go, 30 miles to get healthy groceries has an impact on my ability to also do X, Y, Z, right? Or I can't go drive that distance because I have to work, and so I'm going to choose the unhealthier options that are next to me that are easier. And we're all really trained to do the easy thing, rather than the thing that's going to make us most healthy. And so I think what we do is we do a lot of community listening. We do a lot of going into communities, understanding what's happening on the ground, and then we take that data to people who have the ability to make change to fund programs. And so I do think that there has to be a larger effort to capture those stories, capture those narratives, and then we can also capture some of the quantitative around health outcomes as well.
I'll share too. Your question brought to mind a program that we have at Hennepin Healthcare. And this program is aimed at helping the survivors of violent crimes, gunshot wounds, people coming in with stab wounds. And it's a program that helps survivors maintain their respect and dignity when they're coming into the emergency room, if they lose their driver's license, if they lose their apartment because they couldn't pay rent because they've been in the hospital. This program supports them with all of those things because we know that, as you mentioned, these are all factors that can impact someone's health for a very long time, if not forever. And in this program, survivors are also given an opportunity to meet with a therapist. There's a men's group, there's a women's group for survivors, and we're seeing such a significant impact with this programming. The recidivism rate, so there's a saying, right? Hurt people. So people get, into a fight. They may want to go and retaliate, for example. So what we're seeing is this recidivism rate. We're coming back into the hospital because of another violent crime has gone down significantly since this program. The recidivism rate used to be 36% of people who came in for a gunshot wound, for example, and then coming back. This program decreased it to 3%. So there's a lot that we can do, and there's a lot that is happening that can really help change the trajectory of these young people or these survivors of violent crimes in their lives.
So I'm getting the call. So I wish I had more time to take some more questions, but know that our panelists are going to be here after the panel to answer any lingering questions that you have. As I said, do look into their scholarship and the work that they are doing. They're doing some awesome work. Another round of applause for our amazing panelists. And with that, I would like to pass the baton to my amazing colleague, Director of Federal Affairs for NCQA, Michael Graham.
Hello, everyone. So I know better than to stand between people and food, so just give me like 2 minutes and I'll be quick. But we've heard a lot of information here and a lot of great examples about how organizations can look at their data and look at their healthcare systems and rethink the way that we're engaging and rethink the way that we're approaching health. That's what this is about. Healthcare is not just in the four walls when you're sitting there with a doctor. Healthcare is when you are at home. Healthcare is when you're in the grocery store. Healthcare is everywhere you are. All of those things impact you and your you and the people that we serve and see every single day when we think about healthcare. Our panelists all have some tie back to a healthcare organization, but one other thing that ties them, particularly Dr. Clark and Dr. Vang, their organizations are part of NCQA's Health Equity Accreditation Program. This program encourages organizations to take that equity lens and say, hey, what are we doing with our data? How are we thinking about stratifying our data? How are we utilizing the latest tools and the ways that we know academics have looked at and proved that we improve healthcare for everyone in our communities, and implementing those on the ground? And so we are very, very encouraged and really excited about the opportunities that data stratification presents to healthcare organizations, and encouraged about the opportunities of working with the commission, the caucus on the Commission of the Social Status of Black Men and Boys, the Office of Congresswoman Frederica Wilson, the Office of Congressman Stephen Hertzford, and the Office of Congressman Troy Carter to continue to advance health equity and move forward the needle to make sure that we are addressing, and our healthcare systems are looking at the data and looking at how we can improve healthcare through an equity lens. And we are very encouraged by this conversation, and I hope to have you all here again on May 1st, when the caucus on the Commission for the Social Status of Black Men and Boys will be hosting another discussion around mental health. As we know, May is Mental Health Awareness Month, and so it is a very, very, very timely discussion. Again, thank you all so much for being here, and always, always, always remember, NCQA is your partner in healthcare, and we're here to support you as you all are thinking about healthcare in every aspect and in every manner, from value-based care all the way up to addressing health needs and social changes, social needs of people, and ensuring that there's a change for the betterment of healthcare. Thank you all, and look forward to speaking with all of you outside.